building a virtual medical group without bricks and mortars by using health IT, telepresence, and these things could be very innovative in the future.
Right. The Affordable Care Act does little to bend the cost curve, except that it codifies accountable care organizations. I would argue that California has had ACOs for 10 years, and that is why California's total cost of care is outpacing or underpacing the rest of the nation. So I think, and we will see ACOs, the regs come out a week from Friday, likely, and most of us are holding our breath to see whether they will set the rates at a national benchmark or they will acknowledge and reward innovative states like California and California's medical groups to give us a reasonable benchmark. But they will come out. The initial ACOs and Medicare program will wrap around the fee-for-service side of the Medicare delivery system, and there will be shared savings opportunities, but they will evolve to global risk sharing for providers and communities to essentially be accountable for the patients that live in their community. So we will evolve from a fee-for-service shared savings model in the initial ACOs to a more comprehensive program that will really look like a capitated delivery system with the added benefit for patients of freedom of choice and movement through the entire delivery system.
So do you see if the ACOs are moving more towards a capitated model that you're going to see there's going to be a lot more parity with the integrated versus the delegated models, that they'll be more along the lines the same?
Actually, I think you'll see the delegated model groups develop the ACOs in the commercial model first. They'll be out of the gate first. There isn't much of a difference between what we call the delegated model and integrated systems. Integrated provider systems are in the delegated model. It means they take financial risk and they're delegated administrative duties that health plans would normally perform. You can have an integrated system that can contract to do that. You can have IPAs that are independent of hospital systems. There's a variety of flavors in California around these business models.
Okay, thank you.
Thank you, Dr. Hernandez. Mr. Nastandi.
Thank you, Mr. Chair. And I guess a question of both the doctor and the professor. The duly eligibles, duly eligibility process, is there a way that we can improve it? Can we, I think the stat was 26% of ours versus 13%, I think it was nationwide or something like that. Can we improve on that can we save money in that process by improving on those dualies? And the second question is, Doctor, on your slide sheet you said on how to break the cost curve, elimination of unexplained variations. Can you explain that a little bit? Thank you.
You know, in my 1,000-physician group, we have 20 urologists. And we asked them several years ago, we showed them the data that showed variation in the cost to manage kidney stones by provider. We showed them the data. We did not tell them the right way to care for patients with kidney stones, but we asked them to explain variation. And if they couldn't explain the variation, we asked them to eliminate it. And in fact, physicians, if you provide them the data, managing, especially physicians, primary care physicians, if we look for unexplained variation, whether it's the difference between McAllen, Texas, and San Francisco, where we're at the opposite ends of the Medicare spend, if we show providers, empower physicians and their hospital partners with the data, they will drive out unexplained variation, and they will move towards what I see. If you notice that San Francisco is the number 2 most efficient, high-valued county in the nation for the Medicare program. So I do believe that you can identify and eliminate unexplained variation.
The dualies?
Yeah, so, I'm a commissioner on a county organized health system for Santa Cruz, Monterey, and Merced counties. We are lowering the cost to the Medicaid, Medi-Cal program by about 20%, and we have the highest quality. We have little, if any, access problems. The physicians are full in those counties, are participants in it. That's where the dual eligibles are cared for in those 3 counties. We do an excellent job using a county organized health system model. For me, that is, I think, I would like all dual eligibles in California to have the option of receiving their care. And these are organized, this is essentially an IPA, taking care of the dual or the Medi-Cal population. We're doing a great job. I think it's a model.
Yeah, I mean, I agree with Dr. Degataldi. I mean, you want to take this population out of a fragmented delivery system and bring them into a system that is more oriented around a medical home, coordinated patient care, give them access to the HIT resources to manage all of the chronic conditions that are evident in that population.
Thank you, Mr. Nastandi. Dr. Pan.
Thank you so very much. I want to thank the panelists for the presentations. I'm going to shift a little bit from the medical side to the pharma side. I certainly noted your slide showing that if someone was actually compliant with their medication, or adherent, I should say, that you can lower the overall medical costs. And I've also noticed, I've also seen studies where, for example, a business eliminated the copay for a chronic medication and actually lowered their overall costs, even though they now didn't charge a copay because people were likely to take their medication, therefore were less likely to suffer the consequence of that. Can you perhaps speak to different models that people have had to try to promote increased, more consistent use, particularly in chronic disease conditions?
The only thing I would really say about that is generally I would find if it costs patients anything, if it's a behavioral economic disincentive, which is the geeky term for that sort of movement, patients will take the meds if it's easy for them to get access to. So if they can get a 90-day supply as opposed to just the 30-day, or in some cases where they're moving to, say, only 15-day supplies, if they can have the pills at hand that they need and it costs them very little out of pocket, then they will use it. Beyond that, I mean, there's a lot of innovation going on in the medical device world I know of. It's not so much my field, but where they're trying to do bottles essentially with meters that decide and determine whether or not the pill weight has changed, whether the people have taken it, and then via IT sending a message to their daughter or to their physician. So it's those sorts of things. But beyond that, really lowering the barriers to access is how we deal with the chronic disease from our view.
So if we're talking about populations that may be particularly poor like Medi-Cal, we should really eliminate copays instead of adding copays to medications for chronic disease management, correct?
That would be more along my lines, yes. I mean, they are relatively nominal, and people often, there is some budget scoring generally, but I would say in the pantheon of other costs and potential cost containment measures, the X few millions of dollars sometimes that raising on the backs of the underprivileged and the people who really need these things most is not the smartest movement in my view.
Thank you.
Thank you, Dr. Pan. And if I might just follow up, Mr. Cypher, in that area that you were just addressing, do you have any data that would demonstrate currently what percent of prescriptions in California are paid for by the individual covered versus by a health plan or some other source?
I don't. I probably should have checked that one out, but no.
Well, maybe it's something we could work on together, because
I will be able to track that down pretty easily.
And then part of that question would go to, as we implement reform, some of the objectives that you addressed and that Dr. Pan followed up on, that we be smart in how we make prescribed pharmaceuticals available to patients to achieve the best outcomes and not have a barrier of a copay. Yes. Lead to greater costs. So some sense of the percent that health plans are currently paying for versus the individual has to pay as a copay, or they're shouldering the whole cost on their own.
The one thing I would say is that all the modeling we've had done, we expect a very limited to almost no increase in overall drug sales, overall, as a basis of reform. Mm-hmm. A lot of our view is that there is pent-up need for the populations who haven't had coverage and they have deferred care for so very long. That's where that explosive nature or the growth that will occur in the interim years, in the initial years as well of PPOC implementation, that will take place. We're anticipating limited measures of pharmaceutical growth, but there are, I definitely think the data is important.
Right. Well, your slides are also helpful in showing with the expansion of available generics based on patents running their course, the management of certain chronic diseases can be managed at a lower cost with generics. So
I would say the industry is facing the branded industry, the innovator industry, is facing some difficult times over these next 3 years. I think it was on New York Times a week and a half in front page of Sacramento Bee reprinted I think by 2014, 50 billion in branded meds within the United States will be generic. So
in
those
what
savings
may
will
be a
pass on.
detriment from an investor point of view for
Yes.
the pharmaceutical industry may indeed translate to a benefit to consumers.
Yeah, there will be lower cost generics of those drugs. Yes, absolutely.
Thank you. And then, Mr. Barcelona, you mentioned that some of the groups had been innovative in initiating their own drug trials for diabetes treatment and management. Do you know if those trials included any non-pharmaceutical interventions such as diet, exercise, behavior, education?
Well, not the trials, but that's part of the chronic care regimen for diabetes patients within the groups, yes.
And that is part of the overall management.
Yeah, it's a population health approach. You identify your diabetic patients and you mine the data around all the different doctors in the group who are providing treatment to that population, see where the outliers are, improve on that, exactly as Dr. De Gottalde described. It's very, very effective.
Mm-hmm. And then my final question for Dr. De Gottalde, again, I want to thank all of you for being here this afternoon, but in terms of the economies of scale achieved by the Central California Health Alliance that you alluded to what degree is that management able to invest in prevention and wellness programs?
So not only does this COES cost less per capita for the Medi-Cal equivalent patient in the fee-for-service program, it is providing educational opportunities. It is providing, in some cases, transportation to their providers. It is providing very liberal quality incentives to providers, and is providing, this is very unusual, typically in the Medi-Cal population, you wouldn't see, on the fee-for-service side, we do not incentivize providers to enhance quality, to enhance access, to provide appropriate incentives to keep their offices open after hours so that we avoid unnecessary ED usage in the Medi-Cal population. But something happens when you bring a program down to a community level where the community gets the fact that they're taking care of their own community and they're going to do the right thing. The physicians are all providers in the Medi-Cal program because they get the fact that they're taking care of their community. So something goes on at the level of a COES when the line of sight is these are your patients and your people, your residents of your town.
Great, thank you. If there's no further questions from committee members, I want to thank all the members of this panel for your time and preparation for today's hearing and for your contributions to building a healthy California. Thank you. And as our next panel comes forward, this will be insurance industry and actuarial discussion on premiums. As they would come forward, I'll just offer an editorial comment here as they come forward. There was some testimony in the last panel on the benefits of health information technology, and I'm a big fan of the benefits, and one of my concerns is that we not over-depend on the technology to reduce patient access to a physician when they need to connect with a physician in a face-to-face encounter. And even in those face-to-face encounters, that physicians' eyes aren't directed solely to the computer screen away from the patient. So I know that this is a concern of practitioners and physicians. I think as a committee, as we work to implement the benefits and the economies of information technology, we need to continue to engage physician and patient best practices at the forefront. So with that editorial remark, I welcome members of our insurance industry and actuarial discussion panel, and we welcome Susan Pantelli, Principal and Consulting Actuary with Milliman Incorporated. Welcome.
Thank you. I'd like to thank the panel for listening to my testimony today. My name is Susan Pantelli. I'm a consulting healthcare actuary with Milliman for the past 20 years. Milliman is an independent consulting firm. We consult on healthcare financing issues to a wide variety of clients, including the CBO, the Veterans Administration, and a multitude of health plan government agencies and healthcare provider systems. What I wanted to go over today is how an actuary views setting health insurance premium rates. It's a very data-driven, empirical process that is often misunderstood by the public. So the first thing that we do is we need to understand that we're projecting our experience into the future. We're typically estimating costs 18 months or more in the future. This is because we want to start with a period that has enough information. We can't just look at a month of information because there's too much variation on a month-to-month basis. We need to have a lot of data. So if I'm going to use 2010 data, really right now it's just becoming available because there's a delay. You go to the hospital, it takes time for the bill to be processed. So we like to wait until that happens. So now we're using 2010 and we're going to project it to the future. Well, if we want to project it to the period starting July 2011, that is actually 18 months because we go from midpoint. It's not from December to July or just 6 months because the whole year it's reflective of the midpoint. So we are projecting healthcare costs 1.5 to 2 years into the future, which is a relatively long time. Once we decide on what our base period is, we summarize the current experience. We usually look at it in broad service categories, such as inpatient, physician, outpatient, prescription drugs. I have an example of how we would look at inpatient. We look at it by medical, surgical, maternity. Maternity's one of the easier ones to project. People typically have the same amount of children every year. Once we divide it like this, we look at utilization per 1,000, and that's per 1,000 people, because we don't want to look at how many days people are in the hospital. If our members are growing or going down, the data will. So we normalize it. And then we look at how much it costs. How much does it cost for a day in the hospital? So in this example, the utilization for medical is 56 days per 1,000, and it's $4,815 per day. To get that to a per person cost, I take 56 times 4,815, and then I divide it by 12 to get it to monthly, and I divide it by 1,000 so I can get to my one person and how much I'm going to have to charge one person. Once I summarize the data like this, I look at it, I compare it to a prior year, I try and look for anomalies. For example, if I had an epidemic in 2010, everybody went to the hospital, had swine flu, I don't want to project forward because we're not going to expect that to happen again. This is where I say an actuary becomes a detective, because whenever I'm looking, if my prescription drug costs have gone up, well, I try and then go down into brand generic. If brand's going up, well, therapeutic class, is it cholesterol drugs? I have to understand how the medical care is being given and what the population is doing if I want to project it into the future, if it will continue or not. So once I do my detective work and decide on my base period, then I have to figure out how to project that forward. And this is where the actuarial science comes into play. I project utilization and I project average cost separately. A key piece of experience in both is I look at the historical. What have things done in the past? Of course, the past is always not an indication of the future, but it is one point of reference. On the utilization side, I also have to look at physician practice patterns. They evolve over time as physicians learn, as a former person up here said about practice patterns and doctors getting together and looking at variation. They can change. Change in benefits, the change in the underlying population, an aging population. Selection, which means people select plans in their own financial interest. I'm going to talk about that a little later because it's one of the things that is a more difficult assumption to make. The introduction of new technology, new drugs, also drugs going to generic, which goes the opposite way, which would reduce costs. And then I look at the underlying population health status. We all hear that diabetics are increasing, obesity is increasing. On the average cost side, I talk to provider contracting department, which is usually not an actuary, see what the contracts look like for the following year. I consider new technology that may be coming out. And I also look at intensity. And intensity is when there's two choices with a certain condition. There's a less expensive choice and a higher cost choice. And sometimes it becomes more intense if the population shifts to that more expensive choice. So I take all of these into consideration as I'm going forward. The reason that I put the top two in red is because as an actuary, I'm often asked why premium rates are increasing higher than the medical CPI. Well, the medical CPI reflects a market basket of goods, which is fixed. The only thing in my list, and this is not a comprehensive list, this is my top list of what I look at, the only one that the medical CPI actually takes into consideration is historical experience, the first one on my list. So my answer usually is, well, why in the world would I think it? There's just so much more going on in the medical CPI. So once I've projected my utilization and costs forward, I add in administrative costs and also a future targeted profit. And the reason I'm using the word future targeted profit is because I do not build in anything to, if I lost money last year because I projected wrong, I don't try and recover that in the rates. So I wanted to stress that when, as an actuary, I'm looking at, I am actually developing premium rates, not rate increases. I'm doing the building block on a step-by-step process. I talked about selection as one of my items that I look at. And in the individual market, it's even more important. And I wanted to go through just a really quick example because I think visually it's a little easier to understand. Each star is a person, and this is a small group here. But if I have all my low-cost members in the blue, my mid-cost members in green, and I have a few high-cost members, in this example, the average member annual cost is $55.48. So the people, when they get their bill in the $30,000, these chronic conditions, they are really seeing a value in it. And if they can afford it, they're going to pay. The middle people, they're sort of on the fence, but they may think that they need it. But the people that aren't getting anything, when they get their bill and the premium goes up, they say, this is a lot of money, and I haven't really used it. So if I take 4 of these out, they decide, I don't really need it. My member cost has gone up to $62.38, and that's a 14% increase, and that's not include any other increase. That's just because I lost my members that didn't believe that they needed health insurance. It's a phenomenon more in the individual market than in the group, but it does happen in the group market. Okay, thank you. So, and I also wanted to demonstrate how legislation can affect it. California had a law which put premium rates neutral for men and women. 25 to 29, females are more expensive than males. So males went up, females came down. At higher ages, it's going to be the opposite, but it can cause disruption in the marketplace. So I hope that helps you understand how actuaries view this process. Thank you.
Thank you, and we will come back to questions, but this was a very helpful illustration. Thank you. Thank you very much. And now we'll go to the testimony of Rich Hall, the Chief Actuarial Officer with HealthNet, Inc. Welcome, and thank you for your participation this afternoon.
Thank you, Chairman. It's an honor to be here to talk about this very important issue. My name is Rich Hall. I am the Chief Actuary for HealthNet. I've been an actuary for over 20 years as well. Today I want to talk about a couple of things. One, there are many drivers of healthcare costs. Many have been discussed today. I picked out the 10 that I think are the biggest drivers. I want to go through those. Some of them have been discussed. I'll give a few facts related to that. And then secondly, I want to provide some data on California versus the rest of the country. First driver we talked about earlier is a cost shift from public sector on the hospital side. There's data in a database collected from all the hospitals called OSHPD. It's a database that collects data from all the hospitals, splits out costs between Medicaid, Medicare, and the commercial population. When you look at that, overall, the hospital revenue in California hospitals is 5% greater than the cost. So you could say that's a 5% profit margin. It doesn't exactly equal that, but it's 5% greater, the revenue, than the costs. On the Medicaid side, when you look at a Medicaid population, they receive 70% of the cost in revenue. So for every Medicaid patient, on average, that they see, they lose 30%. On Medicare, that same number is 80%. So for every Medicare patient they see, they lose 20%. So in order to get to a 5% overall revenue greater than cost, obviously commercial's the last to pay to make up for it. That same ratio is 150%. So for a commercial member, commercial meaning insurance company member, that payment is 150% of cost. So when you blend that all together, that's where you get the 5%. So for commercial members in California, paying twice as much as Medicare, Medicaid on average. So I just want to give that statistic. 10 years ago, that same number was between 105 and 110%. So the commercial population was paying 105 to 110% of cost. Now they're paying 150% of cost. So over time, that's actually going to get worse. Why is it going to get worse? Number one, there's many more baby boomers moving into the Medicare ages. Number two, we talked about it earlier, Medicaid, Medi-Cal, and Medicare payments are going down over time. And number three, we have many more, because of the Accountable Care Act, we will have many more patients, many more people moving into the Medicaid space, many more people. Okay, second reason. There's some, for hospitals, there's some unique issues that we face here in California. One, seismic retrofit requirements. That is, obviously, particularly with what we've seen in Japan, et cetera, it's an important initiative. Some estimates say that adds $550 per day just for the seismic retrofit requirements. Again, it's a necessary evil in California. Secondly, mentioned earlier, cost of labor. I won't get into that. My third item that I wanted to talk about driving trends is uncompensated care. Again, we talked about that before, so I don't want to belabor that. But there are some estimates that adds up to 10% in others having to pay for that uncompensated care. Fourth is medical technology. We are living longer lives here in America, but I want to read off some statistics. MRIs and CAT scans utilization have gone up threefold, have tripled in the past decade. Knee replacements are up 70%. Kidney and liver transplants are up 40%. Half the population is on some sort of prescription drug now versus 33% 10 years ago. Those are just some examples. I could go on and on with examples of medical technology, how it's improved our lives, but it drives up costs. Fifth one on the list, mentioned briefly earlier, unhealthy lifestyles. Obesity. 34% of Americans today are obese, and that's growing at 3.2% a year. Obese is considered 30 or more pounds over ideal weight. The costs for an obese person are 42% higher than the average cost of the population. So if you took that number and you said we had, let's say, 10% of our population obese rather than 34%, that would knock 10% off our costs right off the bat. And when you look at other industrialized countries, they do have rates more like 10% or even less. Number 6 on the list, aging of the commercial population. We've talked about it briefly. The commercial population, the group population, is aging. Why is that? A few reasons. Number one, people are entering the workforce at later ages. Okay, so what happens when the population ages? The costs of an older male are 5 times that of a younger male, as an example. So there's a 5 times difference in cost. So in the employer population, when people go into that, when younger people go into that population later, the whole population ages. That drives up costs. Also, the younger population, we heard testimony from Ms. Donahue earlier about her younger population within her small group. they choose not to have coverage, or they sign waivers, as she said. That happens a lot more with younger people than older people, particularly as the costs go up and up. So anyway, and that gets exasperated in tough economic times. Number 7, Ms. Pentelli summarized it perfectly, gave a great example, and that is selection in the particularly in the individual marketplace. Those that don't need the coverage often go without it, particularly if they're younger, healthier. They want an iPad, subscriptions, things like that, rather than having health coverage. And in her simple example, where just a few of the healthy people drop coverage, sent up costs 14%. Number 8, third-party payer. There's not a great deal of incentives to shop in our system today. There's a third-party payer. Imagine if there was a third-party payer for food. You know, would people eat at McDonald's or would they eat at Ruth Chris Steakhouse? And by the way, don't even get me started about McDonald's impact on costs, healthcare costs. But number 9, defensive medicine. This isn't as big as what was once thought, but there have been studies. A recent study showed that 20% of the services that an orthopedic surgeon group provided in a Midwestern state, 20% of them they admitted were for defensive purposes, like CAT scans, MRIs, that sort of thing. And then lastly, healthcare reform mandates. They're a small piece of what drives up costs, but they do drive up costs, and many of them are very good. 100% preventive. In the short run may drive up costs. In the long run, hopefully it'll lower costs. But make no mistake, in the short run it does drive up costs because it takes a while for the impacts of the 100% preventive to take effect. There's unlimited lifetime maximums, removal of certain limits on services, mental health parity, et cetera. Again, small impact, but they do drive up costs. So those are the 10 that I picked. I could go on and list 50 reasons why healthcare costs are going up. But I wanted to mention a few facts. Number 1, the ratio of claims to premiums. If you look at the Department of Managed Healthcare rate filings for insurance companies, and you look at the ratio of claims to premiums, which is often called the medical loss ratio, if you look at that, that has gone up over the past 5 years, which means whatever the rate increases have been, they haven't even kept up with the medical costs when you look at the rate filings. That's the first fact. Second fact, when you look at those same filings, most of the organizations, if not all of them, are already operating above the minimum medical loss ratio that the Accountable Care Act has in it. There's a minimum loss ratio that says if an insurance company runs a medical loss ratio, which is the ratio of claims to premiums, that is lower than the limits put in the Accountable Care Act, they have to rebate money to the customer, which is a very, very good consumer protection. And then the last thing I want to mention is the last panel was fascinating, talking about the integration of physicians and hospitals here in California. If you look at Los Angeles, small group premiums filed with the state in Los Angeles, you look at HMO premiums that are in Los Angeles, they're very organized medical systems that take risk, capitation. Those premiums for the exact same plan design versus a PPO are 30% less. 30% less. That's what the organized medical systems can do. And those are broad paneled organized systems as well. You can narrow those panels and even reduce costs further. So with that.
Great. Well, thank you, Mr. Hall. This combined testimony is very helpful. It was precise, and it gives us some keys for us to better understand both what's driving costs and how carriers and providers, where that money is going. Let me open this to questions of our panel members. Dr. Hernandez.
Yeah, I think the first question will be for Ms. Pantley. And I was really impressed with your little stars when they came away and how it kind of it really kind of put things in perspective. But do you anticipate with the with 2014 just a couple years away, and with the health mandate that everyone has to purchase health insurance, will that kind of level that off and allow that type of cost or cost shifting to not, or that kind of not to occur?
Very good question. That is the idea, and we are hoping that. Right now, the penalty in the first year is relatively low to the cost of insurance. So if the penalties lower, people may not have the incentive to go in. So it will help, and it will get people in. But until the people really feel that they have to go in, we're going to have guaranteed issue then where you can't deny people, which is a good thing. But yet, why would I pay the penalty if I can wait and go in later? Massachusetts, which has something similar, has seen some people coming in and out of the system at will. Hopefully that doesn't go on too much. So it's going to be a learning process, but it is an attempt to try and fix that selection problem.
Okay, and then my next question, and I know that, you made some very good points, Mr. Hall, with regard to your 10 points for cost drivers. And the one that always perplexes me is the cost shift and how you broke down with Medicare and Medicaid at 70%, 80% for Medicare, and then the commercial is 150%. That doesn't even take into account the uninsured as opposed to, these individuals. And this has always kind of perplexed me, but how do you envision stabilizing that? And if you stabilize it, would overall health costs go down? Because there's got to be a way to stabilize and increase the cost at the Medicare and Medicaid level, without affecting the upper end. I mean, what's the answer?
Can I borrow an early testimony? I don't envy you all. It's a tough solution. I mean, obviously, in this state, Medi-Cal, the state does not, is in financial distress. The federal government's in financial distress. It is a big driver, a big stick to reduce healthcare costs is reduce the unit cost payment. But at the same time, given the demand for services in America and the need for services, I don't know that there is a clean-cut solution other than, eliminating things we talked about before. It's education. It's people using PCPs, giving them access to primary care physicians rather than using the emergency room as a PCP. It's maybe some sort of education on healthy lifestyles, particularly for people that may not be educated on that front. But as far as the government, I don't envy your job in trying to figure out how to balance budgets, but with healthcare costs going up at 10+% a year.
You were supposed to give me the answer. Thank you.
Thank you, Dr. Hernandez. Dr. Pan.
Yes, thank you so much for your presentation. Certainly, I think it was Ms. Pantley, you talked about obviously the impact of what happens when healthy people drop out in the system, but I wanted to address sort of the other side of the issue, which is that certainly one of the factors in trying to actually predict your cost in 18 months is your case mix, right, of patients in the population, and who therefore is in your plan or whatever population or medical group that you have to manage. And so there then creates certain incentives and disincentives to have certain types of people in that population, correct? Financially, when you're trying to do actuarial projection?
There does. I mean, we're doing it on a population, not a per person basis.
Right. The population basis. No, if I can reduce the number of people who have certain chronic conditions that I know will cost more money in 18 months, then I will then reduce my costs in 18 months, correct?
If I thought I was going to have less chronic people, yes, that would reduce costs.
Right. So what are you, I mean, and I don't know whether you have the answer to this, but what sort of mechanisms do you think we should are put in place so that we don't create disincentives for organizations to find ways to basically discourage people with ongoing chronic conditions from being in the populations they're trying to serve?
I think one of the things is trying to get more give people incentives to come into the system. And it all comes back to cost. I mean, the people that drop out of the system, even in my example, it's a cost issue. So until we can reduce the overall cost, these lower cost people don't want to come in.
Well, I'm talking about the flip side, which is how do you, on one hand, you're trying to reduce costs so you don't discourage the healthy people that show up, but hopefully you're not reducing your costs by driving out people who actually need the care. Correct?
Correct. I mean, we're just projecting what happens, how we keep those people in the system. I mean, I think that a lot of the integrated and more coordinated care should help those chronic conditions and keep them in the system and keep their chronic conditions from being exasperated. I mean, that's what we really have to do, is manage these patients so that even though they have chronic conditions, and they will be higher cost than the average, but we don't want their chronic conditions to keep getting progressively worse.
I guess, and don't want to take too much time, and maybe this is outside your realm and not of experience, and I don't know if our expertise, but are there incentives we should put in, or places, our mechanisms we should put in place to actually reward the plans or the groups that actually take on the sicker patients, recognizing they're going to cost more, so they know they're going to cost more, we know they're going to cost more. By taking them on, they're now going to, they're going to raise their costs, but yet we know they need the service. So are there mechanisms we put in place so that if you take on the more expensive actuarially, you calculate, you have data saying that if someone has these conditions, they're going to cost more in 18 months, right? I think that there's been enough experience to be able to figure that out. So that information should hopefully be more transparent and available not only to the plans but to everyone, and that maybe we can come up with mechanisms so that costs for those patients, that the plans who actually take them on and are doing a good job taking care of them are actually rewarded and not punished for taking them on.
Well, there is in Medicare Advantage plans, there's an example of they do risk adjust the premiums. So if the Medicare Advantage plan gets a lot of people with the sickest people, they get paid more. So you could take a system like that and risk adjust with the commercial population. It requires a lot of coordination among the insurers, but that would be one way to encourage people to take the chronic conditions.
Yeah, and also, I was going to make 2 points. That was one of them. In the Accountable Care Act for the exchanges, the state exchanges, there is a provision on there to alter payment based off the illness burden of the population. So there's in Medicare it works, and so it should work through the exchanges as well.
And I guess just a final question: as an actuary, what would you describe the state of technology as in actually predicting the costs going into the future to be able to actually do risk-adjusted premiums?
It's grown by leaps and bounds over the past few years. We always want to do a better job. I mean, there's always room for improvement. I think we're good.
How good do you think it is? I mean, what's the amount of variation you can actually predict versus unpredictable variation given a case mix?
Oh, I haven't really.
I was going to say R squared is very low.
Okay,
that's an
thank you.
actuarial term for it's low.
12%. Okay,
yeah. And actually, age sex predicts almost the same amount.
Okay, thank you.
Thank you, Dr. Pan. Ms. Mitchell.
My question was actually similar to Dr. Pan's in terms of, and I'm not sure if it's a fair question to pose to you given kind of the nature of the science that you engage in. But when you look at the slide that one of the previous panelists showed us in terms of how to break the cost curve, if there were any general concepts or ideas you had that would add to this list from your perspective.
Well, everybody's talking about bending the cost curve. I think it's going to take more than one item to bend the cost curve.
Oh, yeah.
It's going to take a lot. A couple of ideas that are my personal favorites are reducing the variation in physician. As someone said formerly, same person with same condition, 5 different doctors. You can have a huge variation in cost. It has to be based on evidence. So use of evidence-based medicine so that we give the best care at the best time to the person. I also think more transparency in the system, and that gets at consumers. But right now, it's very hard for consumers to understand what the costs of the system are. And not only costs, but quality. And that information is so hard for a consumer to get. We need to engage them. We want the consumer to make the right choices, but we don't give them the tools to do that. So those are 2 things. And there's just a lot of inefficiency in the healthcare system, more coordination. People get multiple tests because there's not this coordination. Those would be where I would start, but there's a whole lot more we need to do.
Again, I would point to the example of the organized delivery systems that we have in Los Angeles that costs are the premiums filed with the state are 30% less. So I think an organized medical system can absolutely go a long ways, which can do a lot of the things that Ms. Pentelli talked about. I think education, public educational programs on eating healthy, on exercising, on, I know a lot of those are just, it's going to be like Charlie Brown talking in many instances, womp, womp, womp. But really, I do think that that can help in the long run. Wellness programs. There are various wellness programs. There's one organization that actually puts a person, let's say it's a group of 400 or more employees, they actually put a person on site full-time to discuss diet issues with people, to discuss chronic conditions, to help them navigate through the system. If they have if their child has a certain issue, they become their healthcare expert, local healthcare expert. They build relationships with these people. I think programs like that can work at least for larger employers, and maybe there's a way we can figure out to do that for the mass of the population as well. And it might not be the insurance company that does that because they may not trust the insurance company. It might have to be the public policy or the employer that does that.
I actually had an experience like that as an employer prior to joining the legislature. I ran a large nonprofit organization and partnered actually with a professor out of UCLA, and we were part of a study to really look at how you could bring those kinds of interventions into social service delivery organizations that, for whatever reason, have a higher propensity of obesity and diabetes, et cetera, et cetera. And it really was phenomenal just to have kind of a third party, wasn't affiliated with our health plan. And as the employer, I could see our ratio go down over time, just having that kind of advocate internally to at least, if nothing else, continue to have a consistent, regular conversation about addressing your health in a proactive way, as opposed to disease prevention and being very proactive about health.
Thank you. Just one question for Mr. Hall. You gave a statistic of trends in obesity and that a reduction, I think you said, of 10% would lead to a certain reduction in overall costs. Could you repeat what that was?
Yeah, sorry. It was 34% of Americans are considered obese. If the number was 10%, so that would be a 25%, it would be a 67% reduction in the total number of obese people down to 10% of the population. That's where we would save 10% in overall cost. So we go from 34% to 10%.
Okay.
And we would save, that alone would save, in theory, 10% off the costs.
Great. That's helpful. And do you think the reduction of drinking added sweeteners would help reduce those rates of obesity?
I can just tell you for myself, I've seen what it does. I don't do it.
Thank you very much. I want to thank members of this panel for your contributions and helping inform our conversation today. Much appreciated. And now we're going to move to solutions. We've heard a lot of how we identify cost drivers and problems. A lot of our questions have been looking for solutions. And our next panel includes Dr. Richard Scheffler of the Nicholas Petris Center on Healthcare Markets and Consumer Welfare and the Global Center for Health and Economic Policy Research. Nicholas Petris Center. Nicholas Petris was a former distinguished member of this legislature. And we're also joined by Gerald Kaminsky, Professor of Health Services, UCLA School of Public Health, Associate Director, UCLA Center for Health Policy Research. Thank you, gentlemen, for your patience this afternoon, for your preparation and anticipated contributions. We've allocated you each about 7 to 10 minutes, and we'll be liberal and let you go up to the 10, but then we will give you a high sign. Thank you for joining us, and we'll start with Dr. Scheffler.
Well, thank you, Mr. Speaker. I've had an enjoyable day, and listening to the testimony, it's been an eye-opener for me. I drove down to Berkeley with the magic bullet in my hand. I had an implementation problem, however. Could not get it through the metal detector to get into the room. So I'll have to do the best I can with what I know. First, a few comments on some of the testimony. Health insurance costs have gone up in California about 8%, as you've heard, but I think the increase has been much larger than that, because the health insurance product that is being sold now is very different than the one that's been sold the year before and the year before. They have higher co-payments, higher deductibles, and often fewer benefits. So there's more out-of-pocket spending. Therefore, the actual cost is much higher than the 8% that you've been hearing. And I think we need to recognize that the consumer certainly thinks of it that way. They just don't think of the 8% increase in the premiums. Healthcare costs, there's no doubt, in the United States are high. They're driven by a few things. One of them is Americans like technology. I certainly do. I had to buy this universal remote to run my other 3 remotes. And of course, only my 18-year-old knows how to use that remote. We all have that problem. Well, the healthcare cost situation is like that. Over half the increase in healthcare spending in the United States, half of it, is due to new technology, not what we've been talking about in this room. And that new technology is new procedures, it's new drugs, and sometimes it's just a slightly newer way of doing an old thing. But we value that. The system will pay for it, and consumers definitely want it because they want the latest and the best. And so we have an amazing problem of dealing with a system and a culture in a country that loves technology. So how to deal with that problem is a tough one. I'll come back to it in a moment. I want to comment a little bit on the prevention. My colleague from Stanford, who is a distinguished person and in the room, and a physician, my math is a little bit different than his. I'm in a school of public health, so I find a lot of community-based preventions work pretty well when they're population-based. And so I think you have to have them in different categories, and we need to understand that you know, the obesity problem is not going to be clinically solved. It has to be solved at the population level. And also problems with drug and alcohol and other behavioral problems as well are not the kind of things that have obvious clinical solutions. And they need to be population-based and community-based. Having gotten that off my chest, I've been holding that for a while. I think we need to understand that the United States spends a lot, but we don't actually get much more than other countries. I run a global center, and if you actually look at the rates of services, the number of visits or the number of days in the hospital, they're fairly similar to the other countries in Europe. What we do is we pay a lot more for them. And some of the problem we have is the input pricing and the payment system in the healthcare system just grossly overpays for services. So what's the biggest problem we have beyond that? I would say that about a third of what we produce in the healthcare system is waste and inefficiency. I not only say that, but there's documented evidence all over the country, from the National Academy of Sciences to many other documented studies. Now, a third is a rough number. It could be 30%, it could be 40%. It's one of those ballpark kinds of things. What do I mean by that? You know, what is this waste and efficiency that we're talking about? Well, some of it is duplication of services. How many people on this panel have had the doctor, the physician, do the same test on them multiple times in multiple settings, or if not you, your relatives or people you take care of, with no value at all other than collecting another fee for the particular test? Unneeded, unnecessary care. How many things are done in the healthcare system that have no obvious benefit to the patient? And in fact, lots of things not only have no benefit, they have a considerable harm. So, and we see studies now saying 100,000, 150,000 people are actually killed in hospitals by mistakes and unnecessary treatment. These are documented numbers, and that happens in California as well as all over the country. There are medical mistakes. Some can be corrected. Some are just the mistakes that happen because medicine is an art, not a science. But there are some obvious mistakes that hospitals and providers make. The third or the 30% is a huge number in waste in our healthcare system, producing no measurable health improvements. And I think that's where we need to drill down. We have amazing medical centers. We have amazing people in California who need to be able to drill down and figure out a better medical model and a better way of delivering the kind of care and services that our population deserves and that we ought to provide for California. And I think we can be a leader in this area. We have the know-how, we have the people, we have the medical research, and instead of it trying to figure out how to produce new technologies, some of it needs to be turned by this legislature and incentivized to figure out how to deliver a better product that's more efficient and less wasteful of the important resources that we have. Now, there are some attempts to do this. Being an economist, you wouldn't be surprised that I would move to the issue of, how you pay people, because that's about half of what economics is. We believe that money and payments matter, incentives matter, and I was toilet trained in that to get my PhD in economics. I'm not in public health, though I'm in the public health school. The latest vogue in payment strategy is called bundled payments. This is the notion that if you want to integrate a system, you can't just produce Kaisers all over the world or HMOs, but you want to somehow or another give it incentives to have services integrated. So one integration, the biggest one, of course, is inpatient and outpatient integration. So the bundled payment is the notion of giving one payment for both the inpatient and outpatient services and saying, you figure it out how you're going to divide this up. So if you had a heart problem and you needed a bypass, it would cost $120,000, give or take. And that would include the fee for the surgeon, the pre-op care, the stay in the hospital, the post-op, and the follow-up. $120,000, here's the check. That's the episode, that's what we're going to pay you. This is the most effective tool in bending the cost curve now nationally. And most analysts who look at that, if you're thinking about a 10% drop in bending the cost curve, which would be a lot, you wouldn't get that immediately, but 10% is a lot. Half of it, people believe, will come from this new incentive of bundled payments, half of it. So that's a pretty big lever and a very important lever. With this, and you've heard from the previous panel or two panels ago about pay for performance, this is a very important mechanism. And it's also, California's at the forefront. They've been testing it in medical groups. They're now willing to increase the incentives up to, you heard, up to 20% of your salary. That will have some bite. But pay for performance is happening in the Medicare program, and in fact, it's happening all over the world. We recently did a study in Berkeley looking at all the OECD countries, and virtually all of them are using pay for performance mechanisms. What does this mean? That means instead of paying fee for service for more, you're paying on outcomes or value or quality adjusted outcomes. You're saying, we want people to get better, we want them to have good services, and we're going to give you a payment or a bonus for that if you do that. It's amazingly effective, and it's a very important tool. But it's a very flexible tool. If you want to provide more services in rural areas because they're underserved, you can have a pay for performance in rural areas, and you can pay providers more and bonus them and hospitals for doing that. If you want to serve the underserved population, the Latino population, or the Asian population, or whatever populations are underserved, you can provide bonuses for providers who take on those populations. So this is a very important tool, and it's one that really drives behavior. And so I would encourage you to look at this further. People have talked about chronic care of the elderly. There's no doubt This is the low-hanging fruit. We need to deal with chronic care in the elderly. The most cost-effective solution that I've seen in that is the use of case managers, people who can coordinate the care and make sure that the elderly get the right services, they're coordinated and not duplicated. Case managers are really the answer, and we want to be growing them and using them more. You've heard about the integration of care. I'm a big believer in integrating mental health and non-mental health services. Mental health is only 10% of the budget, but people who have comorbidities spend 5 or 6 times more than the average population. We need to integrate those services. We need to have more primary care. We need to improve primary care delivery, nurse practitioners, physician assistants. We really need to focus on looking carefully at scope of practice laws in California. They're way behind the national average and what's allowed and what can be used. IT is important. As you mentioned, I don't think it's a magic bullet at all. I think it can raise utilization as well, but it's still the right thing to do. And lastly, I think to look at this technology problem, we really need to pay for new technologies that work, not just new technologies that are produced. Thank you very much.
Thank you, Professor. Very helpful. Before questions, we'll move to Professor Kaminsky. Thank you for joining us this afternoon.
Thank you very much. So my name is Gerald Kaminsky. I'm a professor at the UCLA School of Public Health, where I've been for 22 years, and I'm also Associate Director of the UCLA Center for Health Policy Research. And I think Marion Mulkeys was earlier today awarded an honorary PhD. I think she actually was given my degree. I noticed that my degree didn't show up on the listing, so I think Marion somehow got my PhD reallocated to her.
That's because she's a Berkeley graduate.
That's it, because she's from Berkeley. Well, I'm a proud graduate of the University of Pennsylvania. So my testimony today, I'd like to focus on comments related to rate regulation and a topic that came up earlier in some of the testimony. And I'd like to address 3 things. One, what do other countries do with regard to rates and rate regulation? Secondly, what experience do we have in the United States with rate regulation? And third, what can California do? So starting with what other countries do, it's really no secret. We've been talking about healthcare expenditures, and expenditures, as every student knows from Econ 101, is equal to the product of price times quantity. So if we're talking about controlling healthcare expenditures in California, what European countries do is they explicitly regulate the components of that equation. They either explicitly regulate expenditures, prices, quantities, or some combination of those. Now, I recognize that rate regulation is challenging in the United States, but the fact is that European countries control their health expenditures by explicitly regulating payments to healthcare providers, facilities, and services, which include pharmaceuticals. They establish global budgets for hospitals. They limit the supply of high-cost technology such as MRIs. And they regulate the ability of private insurers, where there is a private insurance market, both nonprofits and for-profits, to determine what products and benefits they can choose to offer. So they regulate along a broad spectrum. The point I want to emphasize today is that cost controls are effective in other countries that are willing to intervene in healthcare markets. And it's because other countries recognize that healthcare, despite over 3 decades of efforts to convert healthcare into a commodity in the United States, does not follow the same market principles as most other commodities, not because of excessive government intervention, but because of the fundamental characteristics of the market that violate the basic assumptions of competitive markets. Other countries recognize this, and that healthcare, for example, is not the same as the market for computers, whereas in the U.S. we're still wasting time fighting this battle and trying to fit a square peg into a round hole. So what experience has the U.S. had with rate regulation? Well, the best example that I'm aware of is the state of Maryland, which has employed hospital rate setting for all hospital payers, including Medicare, Medicaid, and private insurers since 1974. So the question is, has Maryland been successful in controlling the rate of growth of hospital expenditures since creating this rate regulation mechanism almost 30 years ago? The simple answer is yes. In 1976, Maryland costs per hospital admission were 26% above the national average. In 2007, they were 2% below the national average. During the period from 74 to 2007, Maryland had the second lowest rate of increase in hospital expenditures in the U.S. During the same period, California ranked 18th in the nation, but was still slightly above the national average. And we saw testimony today that California is doing well, particularly when you risk adjust or account for differences in California's population. We're doing well, but not as well as Maryland has done over the last almost 30 years. Now, to put this number in context, if the national growth rate had matched Maryland's growth rate from 1974 to 2007, as a nation, we would have saved $1.8 trillion in healthcare expenditures. So if Maryland's been so successful, why haven't other states widely adopted this all-payer rate-setting approach? Well, the fact is that New Jersey, Massachusetts, and New York all had successful all-payer rate-setting programs prior to the introduction of Medicare DRG reimbursement in 1983. And it was a real quirk, and I think this is a good example of the law of unintended consequences, that when Medicare adopted DRG reimbursement in 1983, it basically created an incentive for these states to dissolve their all-payer rate-setting systems despite their success, because the formula for Medicare payment under DRGs was more generous in these states than the systems that they had in place. So they opted out of their system and decided that they would just go with the Medicare system and brought more revenue into the state that way. I think that was a real flaw in the introduction of that legislation in 1983. Nevertheless, those three states still had lower rates of growth since 1974 in their hospital expenditures relative to California. So what can California do to control healthcare expenditures? Well, somebody who started his career 26 years ago in Washington, D.C., working for the Prospective Payment Assessment Commission, one of the things I learned in D.C. was that we never let the best be the enemy of the good. So in my judgment, there are a variety of areas where California can move forward that are both politically feasible and that will significantly increase the accountability of insurers and healthcare providers, thus exerting additional downward pressure on rising health insurance costs and premiums in the state. And I have two specific areas of recommendation. One is to develop a robust rate review mechanism through full and timely implementation of SB 1163. So SB 1163 establishes a standard for transparency and rate review that will benefit all of California as the state transitions to full implementation of the Affordable Health Care Act in 2014. The level of reporting required by SB 1163 will greatly enhance consumer information and permit for the first time an independent assessment of the reasonableness of proposed rate increases across the wide variety of insurance offerings. So when I buy a car, I can go online and find a ton of information about the actual cost of producing that car. And as a result, because there are a lot of sellers of automobiles, I'm very well armed to go into a price negotiation and come away relatively successful. I think that SB 1163 takes a huge step towards providing Californians with essential information, allowing them to shop for insurance on the basis of price. However, I would recommend that the legislature consider going one step further than SB 1163 by allowing the Department of Insurance and the Department of Managed Health Care to disallow premium increases that are identified as unreasonable. In my opinion, SB 1163 does not go far enough in this regard. My second recommendation is to develop an all-payer database for independent assessment of health utilization and expenditures. You heard testimony in the prior panel about how actuaries forecast and analyze rate reviews, and that requires data. The National Governors Association supports the creation of all-payer claims databases in all 50 states. Information on this effort will be discussed on March 24th at a briefing in Sacramento being sponsored by the California Healthcare Foundation. California currently has an all-payer data set for hospital admissions, which is collected by the Office of Statewide Health Planning and Development, known as OSHPD. However, this data set applies only to hospital inpatient admissions. And because it only applies to those admissions, it's missing data on other important sectors of the healthcare delivery system, and thus cannot provide a complete picture of all the cost drivers in California. Furthermore, the OSHPD data does not contain information on the paid amount for hospital admissions, so it's virtually impossible to determine actual cost for inpatient care. 13 states currently have such all-payer databases, which collect data on all private and public insurers for multiple sectors of healthcare services, including hospital, inpatient, and outpatient care, physician services, laboratory and diagnostic services, and pharmaceuticals. So if one of the state's goals is to encourage a high-performance healthcare delivery system, this type of information in an all-payer claims database is absolutely essential. I urge the legislature to consider introducing a bill to create an all-payer claims database in California, building on the success of OSHPD's data collection efforts currently, and I urge you to do it during this legislative session. Thank you for the opportunity to address you today on this important topic.
Thank you, Professor Kaminsky. Both of you, we appreciate these contributions. As I'm looking around, I have one member. Any questions, Ms. Mitchell? Okay. Let me just conclude with a couple of questions along with my thanks. Professor Kaminsky, your recommendation is that in addition to rate review, specific rate regulation would be the best mechanism to try to control or predict rate increases.
I am in favor of rate regulation. I think that the review and the finding of rate requests that are unacceptable or unsupportable is insufficient. I think the state should have the authority. I think that the two agencies that regulate insurance should have the authority to deny increases that are determined to be unreasonable. And I think with the review process and the tremendous amount of transparency that's going to be available under rate review, if something is unreasonable, why, in fact, would we allow that to go forward?
Thank you. And then a question for either or both of you. Kind of big picture, we're moving towards 2014 implementation of the exchange in California, implementation of expanded access and eligibility. What would be your biggest concerns about how we move into that? I think one of the promises of the federal reform is using a free market system where those that are offering products have to offer like products, and that the market will, through competition, drive down some of the costs. Yet competing with that ambition, we have trajectories of illness and disease that continue to go up, and likely, I think a fair prediction that costs will continue to go up. So with those kind of countervailing components, what would be your greatest cautions to us or recommendations about how we implement the exchange in California?
Well, Jerry, I'll go first. Yes. So it's a good question with a very long answer, but I'll be brief because the afternoon is moving on. I think that the exchange kind of reminds me of, shopping for an airline ticket, getting online and looking at the various seats and options, and whether you sit on the aisle or you pay $25 more for a better seat, and tinkering. And I think consumers are getting used to that. But we need a standard product, and I think the federal health legislation has that. The danger of allowing top-ups or other things to be sold on it was brought up by the actuaries earlier. You sought to sort out risk selection. people who want that particular benefit, people who generally select plans, for example, with prevention services are actually healthier on average than people who don't select them because they care about their health and they take care of themselves. So there's all sorts of interesting risk selection things, and that would start to really screw the market up. So I think initially I would be very cautious, and I would have standard products, and I would let whoever can deliver this standard product and that's well audited and the quality is good in the marketplace. And then there'll be, this is from international experience, there'll be 2 or 3 years of rounds. And you'll end up with many plans, and then it'll sort down to some reasonable number. Hard to know what that's going to be, 6, 8, 10. And then I think I would allow some more topping up or competition, because the pools will be big enough at that point. The problem with risk selection is the small individual pools. If you allow that to happen initially, I think it'll just screw this market up. Once the market gets big enough and you have the big players, then the risk selection, I think, is less of a problem, and then you can allow that. So I think the market has to go slow and move in that direction. Otherwise, I think you're going to have a big mess on your hands.
Thank you.
So I think Richard hit the most important concern right on the head, and I share the concerns. I have a slightly different take on it. So the federal legislation defines tiers of benefits and a standard benefit package, but there's still a lot of uncertainty about how standard those tiers will be. And I think what the California legislature did last year was, in its wisdom, created an option to actually create standardized products within the exchange within those tiers, because as I interpret those tiers right now, a bronze plan, although it has to spend, the premium has to cover 60% of the actuarial value, there are a lot of different ways to present that product. And the more varieties of bronze plans that we have that all meet the 60% requirement, but nevertheless are an infinite variety, begin to segment risk again. And I think the whole purpose of the bill, and for it to be successful, is to pool risk. We saw examples, and the LA Times had an article earlier, either late last week or earlier this week, about premium increases of 60 or 70% that some Californians are experiencing in an insurance product where there are 900 people buying the policy. We want to avoid policies that are segmenting our population within the exchange into smaller and smaller groups. We want to pool the risk, and that way we'll get the kinds of savings and keep small groups of individuals from experiencing these large premium increases when a couple people leave or when one person has a bad experience.
Right. The earlier slide of the leaves.
That was an excellent illustration of that.
Healthy people. We want to have a lot of leaves and spread the.
If you spread that across
risk.
1 million people, one person with a high cost case is pennies.
Right. Great. Thank you. Other questions, Dr. Pan?
Oh, well, actually, actually, one of the things since you're in public health, both of you, this is one of my favorite books, Why Some People Are Healthy and Other People's Are Not.
Yes.
What do you think are the opportunities in terms of, because you touched on, in terms of behavior and some of the other things, and we know that that's really the bigger drivers of health. We have to deal with the health care costs for the health. But in terms of improving health, what do you think are opportunities for us to do that in the context of trying to reduce the cost of health care here in California?
Well, that's entirely what the whole School of Public Health at Berkeley and UCLA does. So it would be, if I didn't say everything in our school, in the School of Public Health, I would have problems when I drove back to Berkeley. But I think the behavioral ones would be the number one issue, and that goes to what people eat and also drink and other kind of behaviors. And of course, we know about smoking. Those are the huge. Smoking still is the number one cost issue. When you look at costs a different way, it's not only the cost of health care, but you look at the the cost of the disease and productivity and lost life and all of that. You're still going back to smoking being the number one cost driver. And obesity, of course, is coming up really rapidly. So when we think beyond the healthcare sector, which is what public health does, we've been focusing on the delivery system here, I understand that. But you gave me a chance to think broader, and I think I think that way. I think there are a lot of good community interventions. California is set up in very good models for doing that, and I would want to promote those. I've done a fair amount of work at my research center on something we call social capital, connection in the community and networks. It's amazingly powerful in reducing healthcare costs. If you want, I can send you a bunch of papers that we've done and documented that, and I think there are huge possibilities on that side about community interventions on networks and social capital and its relationship to health.
Yeah, and I would just echo those comments. I mean, I'm trained as a health economist like Richard, and so I'm a firm believer in incentives and also access to health care and making. I've dedicated my career to working for identifying ways of making health insurance more affordable. So I'm a firm believer that access to insurance is an important consideration. But I also have lived in a school of public health for 22 years, and I can't help but have absorbed that perspective and recognize that the biggest opportunities for improvement of California's population, the health of California's population, is going to come from things other than the healthcare delivery system. It's essential that we improve access. The Affordable Care Act is going to do that. We need to continue to do more because there are still people who will fall through the cracks. But public health education, behavioral change, and dealing with issues related to obesity and smoking are going to continue to be challenges. I think that the biggest challenge that we face is educating our children to live healthy lifestyles.
And actually, I would be, as someone who taught community development at UC Davis, I'd be, and done some work in social capital, I'd be very, very interested in your papers on social capital and health.
Well, I'll be happy to send those along to you. And I just want to take one pot shot on this rate review, rate regulation. I think it's an idea worth thinking about. I'm not as convinced as my colleague from UCLA, though I think there's some merit to giving it some thought. But I am convinced that one of the policies we shouldn't use is the one we use now, which is getting certification by actuaries, because they have a particular science and a way of doing things, and actuaries generally don't get fired or lose their job for projecting too high. So I think that that science needs to be looked at. I realize it has some public trust because it sounds good, like a CPA and the like, but I think that this is a much more complicated problem, and actuaries are a piece of it. But to give them the total stamp of what's good or bad in the review, even for a public humiliation by the Department of Managed Care, the health insurance is not enough. I think we need to have other people look at it. And it's a good science, but it poorly predicts healthcare costs. And actually, their predictions that are fed into their premiums actually become part of the problem, not the solution.
Thank you. I want to thank you both for your patience and your contribution this afternoon. Thank you. We're now going to move to public testimony, but I don't think we've had any sign-ins with the sergeants. But now is the time if anybody wants to step up to a microphone and offer any observations or recommendations. Are there any public members who choose to make a comment? Seeing none, we thank all of you for your patience and participation this afternoon. I think this has been a most informative panel. I want to thank co-chair Dr. Hernandez and all the staff for your excellent work in putting together these panels. Our joint committee will stand in adjournment.